Hello, it's good to be with you today. I want to first take this opportunity to recognize the editors, Dr. Gudis, Dr. Lee, and Dr. Kennedy, for this incredible undertaking called Rhinology Worldwide, this repository that'll be created to share knowledge with practicing otolaryngologists and trainees all around the world. My name is Pete Batra. My affiliation is the Rush University Medical Center, where I serve as a professor and chair of the Department of Otorhinolaryngology. My charge in this textbook is to speak to you on histopathology of the nose and sinuses. I don't have any relevant commercial disclosures. This is the outline. We're going to spend a little bit of time first speaking on the normal histology of the nose and sinuses. I'll spend a fair bit of time speaking about the histopathology of chronic rhinosinusitis. There's new emerging data on the implications of structured histopathology in management of patients. Our group has done a fair bit of work on this, so I'll speak to that and how this may enhance the care of your patients. We'll talk about the histopathology of fungal sinusitis, and then we will wrap up with the histology of benign sinonasal neoplasms, specifically speaking to inverted papilloma and the common fibroosseous lesions. So first, moving on to normal histology, I want to credit some of the images that you'll see specifically in this section to Dr. Bruce Wenig's textbook on non-neoplastic diseases of the head and neck. This is an incredible textbook, and I would refer you back to this if you're interested in learning more about histology of the nose and sinuses. As you will see here in this endoscopic view, the nasal lining, the initial mucosa within the nasal lining is more like skin, the keratinizing squamous epithelium with an underlying subcutaneous tissue that has adnexal structures like hair follicles that you see here. And at the limb and nasi, this will transition to more of the sinonasal mucosa, which is the respiratory epithelium. And when you look at this under the microscope, this is what you would expect to see. You see the ciliated pseudostratified columnar epithelium. This sits on top of thin submucosa with the seromucinous glands that you see here that are arranged in this very distinct lobules. At baseline, there is a mixed inflammatory infiltrate in the normal mucosa. And this is comprised of mature lymphocytes and scattered plasma cells. And you'll notice that as we look at tissue from patients with chronic rhinosinusitis, specifically in the setting of nasal polyps, this inflammatory infiltrate will skew more to eosinophils. You'll also notice that there's a distinct vascular component of these large, thick-walled blood vessels, which have a very prominent smooth muscle wall that is evident, especially when you look at the inferior and middle turbinates. This resembles erectile tissue, and we know that with the nasal cycle, this tissue can swell and shrink, and in the setting of patients that have chronic inflammation, perhaps related to allergies, this tissue can enlarge over time and can contribute to nasal obstruction. When we look at the olfactory mucosa, as you see on this sagittal depiction, this is typically confined to the superior nasal cavity. It will involve the superior portion of the superior turbinate, the olfactory cleft, so the cribriform plate, and also the upper 1/3 of the superior nasal septum. And what's interesting is that as we age, this distribution will become more patchy due to multifocal replacement by non-olfactory mucosa. When you look at this histologically, you'll see three types of cells that will compose the olfactory neuroepithelium. You'll see the olfactory cells, as you see here, but you'll also see stenticular epithelial cells and these regenerative basal cells. So the olfactory epithelium is comprised of these three cells. Then these nerve fibers will traverse the cribriform plate of foramina and will then synapse with second-order neurons within the olfactory bulb. Looking at this histologically, here you see the olfactory epithelium. You'll see the submucosa, again with these Bowman seromucinous glands, and you can even see a nerve fiber down below with this arrowhead here. So let's talk a little bit about the histopathology of chronic rhinosinusitis. I will first go a little bit through the definition and diagnostic criteria, and then we will talk more about the histopathology. So chronic rhinosinusitis is defined as sinonasal inflammation that persists for 12 weeks or greater and is usually designated by symptoms that include 2 or more of the following: nasal blockage, obstruction and congestion, nasal discharge, which can be anterior or posterior, facial pain and pressure, and reduction or loss of smell. This diagnosis must be confirmed by objective criteria. If you were to look endoscopically, this could be due to purulence, polyp, you see here, or edema coming from the paranasal sinuses or the osteometal complex. You may see changes on CT where you see mucosal disease or air fluid levels. And more simplistically, this is divided into CRS with nasal polyps or without polyps, strictly based on the presence or absence of nasal polyps. So here again, you see the normal paranasal sinus mucosa. You see the respiratory pseudostratified columnar ciliated epithelium, submucosa with the seromucinous glands, and here is a nasal polyp. And you can see here now, again, there is the pseudostratified squamous epithelium, but you can see transitional or squamous epithelium. You see this very loose stroma with edema. The glands are much more sparse, and there's abundant inflammatory cells. You see all of these eosinophils within the submucosa. And throughout this portion here, I will continue to show you multiple histologic examples of this with key histologic features. So, as I had mentioned earlier, the traditional kind of phenotypic differentiation is based on presence or absence of nasal polyps. And we know that the polyp variation portends perhaps more severe inflammation, higher risk of recurrence, but we know there isn't just a clear-cut division between the polyp and the non-polyp patient, and it likely represents a continuum with some phenotypic differences at the end of the spectrum. Now, there's been a fair bit of work that's been done by many colleagues across the country and the world, really, looking at endotyping as a way to subcategorize the disease by distinct cellular pathogenic features. And we can look at multiple biomarkers such as IgE, presence of tissue eosinophilia and cytokines, and it really gets to this concept of precision medicine to guide treatment of chronic rhinosinusitis. So this type of construct offers several advantages. It's a way to predict a risk of disease recurrence or further progression, select better responders to treatment, and then use this as a way to identify innovative therapeutic targets. So here you see another histologic example, and really this classic description of chronic sinonasal allergic inflammation, which is often what we see, is really not a sufficient categorization of the underlying tissue. And the more detailed standardized reporting can differentiate between the eosinophilic and the non-eosinophilic variants and can have treatment implications, whether it's macrolides for the neutrophilic CRS or oral and topical steroid therapies and biologics for the eosinophilic CRS. Richard Harvey's group was the first to report this. This was published now a decade ago, where they showed that polyp patients had high tissue eosinophilia, greater than 10 per high-powered field. And what they recommended was that this assessment of tissue eosinophilia should be incorporated as part of a structured histopathology report in routine clinical practice. And when I moved to Rush at the beginning of 2014, I convinced the pathologists here that this would be a good way for us to manage our patients, and really has been part of our standard histopathologic reporting over the past 8+ years. This is a standard report that we receive at Rush University Medical Center. They will report on the type of tissue that's present. They'll report on the overall degree of inflammation, whether it's mild, moderate, or severe. They will give us a eosinophil count per high power field, whether it's less than 5, intermediate when it's 5 to 10, or high when it's greater than 10. They'll comment on the presence of a neutrophilic infiltrate, basement membrane thickening, presence of subepithelial edema, and then some other more interesting things such as mucosal ulceration, squamous metaplasia, fibrosis, presence of charcoal-laden crystals, and eosinophil aggregates, which has been an interesting thing that we have learned, and I'll speak to that more in just a little bit. So we have done this for all of our CRS with or without polyp cases, and it's been an important area of research for us, resulting in 13 publications over 5 years, with several that are currently in different stages of development. I also want to acknowledge multiple collaborators who've done an incredible amount of work and really a lion's share of work in our team with my colleagues, Dr. Tajuddin and Dr. Papagiannopoulos in the section of rhinology, Dr. Madavinia from the Division of Allergy, Dr. Gattuso from the Department of Pathology, and several other collaborating physicians at Rush, residents and medical students who have helped put forth these multiple research projects. So I'll speak to a few selective studies and share with you some of the knowledge that we have gained from these studies. So the initial report focused on 99 patients where there was ethmoid sinus tissue removed during sinus surgery. There was 43 patients that did not have polyps and 56 that had presence of polyps. And what was interesting is that overall inflammation did not appear to differentiate between these two phenotypic variants. However, in the polyp patients, there was a statistically significant increase in basement membrane thickening, subepithelial edema, fibrosis, presence of tissue eosinophilia, and also tissue eosinophil aggregates on the tune of threefold for the aggregates and twice as likely to have high tissue eosinophilia. We also noted that on the CT scans, patients that had higher Lund-Mackay scores, this was associated with increased eosinophilia, eosinophil aggregates, basement membrane and fibrosis, basement membrane thickening and fibrosis, and the SNOT-22 scores were not associated with any of these objective parameters. So you'll see here, this is where you see submucosal edema, which is quite severe. You see sparse seromucinous glands. And in this hair, you see the basement membrane thickening in this polyp tissue. And also you see these eosinophil aggregates, which is really interesting because this was more common in the polyp patients and patients with higher Lund-Mackay score. And this may represent a surrogate marker for more severe disease, as this is due to more vigorous eosinophilic activation. This is certainly an important area of emerging research for our group, as we have learned from these different studies. So this was followed up with another study by my colleague, Dr. Tajuddin, which was published in the Laryngoscope. And we looked at objectively patients requiring oral steroids for controlling mucosal inflammation in patients with CRS, again, with and without polyps. And again, just about 100 patients in this study. We looked at their SNOT-22 scores, their endoscopy scores, and also the cumulative prednisone dose requirement at 1, 3, and 6 months. And this is a representative polyp patient. You can see the polyps on the left side of the nose, and you see severe pacification on the CT scan. And what we found is that the CRS patients with eosinophilia in general, required greater cumulative steroids relative to controls at all 3 post-op time points. And patients with tissue eosinophil aggregates required the highest cumulative steroids at 1, 3, and 6-month post-op intervals. And what was interesting is when you removed the eosinophil aggregates from the eosinophilia group, there was no differences whether patients had tissue eosinophils or not. So it seems to be that it was really the eosinophil aggregates that seemed to be the main driver for the need for post-op steroids. So you can see here for the SNOT-22 scores at baseline, again, the 3 bars represent, the blue is no eosinophils, no eosinophil aggregates. The orange is yes eosinophils, but no eosinophil aggregates, and the gray represents yes eosinophils and yes eosinophil aggregates. And you can see post-op, the SNOT-22 scores improved in all 3 categories. And here you see the modified Lund-Kennedy scores, again, improving in all 3 groups, still higher for the patients that have eosinophilia and eosinophil aggregates. And again, this tissue eosinophil aggregates was the largest driving factor for increased prednisone requirement after sinus surgery to control the mucosal disease. I think this is an important counseling point for patients, and we often will do this during the first post-op visit, review the structured histopathology, and counsel patients accordingly. We've also looked at other subtypes of CRS. We have a large tumor practice with sinonasal malignancies at Rush, and so we have looked at the structured histopathology of radiation-induced CRS. And in this specific study, we compared 15 radiation-induced CRS patients to 43 CRS without polyps and 56 CRS with polyps. And what we found is that the CRS that is radiation-induced has increased squamous metaplasia and subepithelial edema relative to CRS without polyps. These radiation-induced CRS patients had fewer eosinophils and less basement membrane thickening relative to the polyp patients. They also seem to have a greater mean Lund-Mackay score compared to CRS without polyps. And these are a couple of representative histopathologic images of these patients from the radiation-induced CRS. You can see the squamous metaplasia of the mucosa that you see here, and again, very severe subepithelial edema, as is evident on the right-hand side. We also looked at odontogenic rhinosinusitis as well, comparing 23 of these cases to 38 patients with CRS with nasal polyps and 53 without polyps. And what we found is that the odontogenic variant exhibited increased moderate to severe inflammation relative to CRS without polyps. There was relatively less squamous metaplasia and fibrosis relative to the nasal polyp variant. Here you can see on this histology, these are odontogenic rhinosinusitis cases. You can see very severe inflammation in this representative histopathology. You can see the underlying inflammatory cells. And what we found, interestingly, is that there was a fair bit of eosinophilia in this variant, but less so than the polyp patient, but certainly more than the CRS without polyps. And it's possible that this higher tissue eosinophilia may explain why some of these cases of odontogenic rhinosinusitis can be recalcitrant to medical and even dental therapy and may go on to require surgery. So that is a summary of what we have learned. And again, there's much more to be learned and continues to be an important area of research for our group. I'll now switch gears and talk about the histopathology of fungal sinusitis. Recall that broadly, this is classified into the non-invasive and invasive variants. Under the non-invasive category, we have the superficial mycosis, fungal ball, and allergic fungal sinusitis. And under the invasive variant, we have the fulminant acute invasive fungal sinusitis. And then you have the chronic subtypes with the chronic invasive fungal sinusitis and the chronic granulomatous fungal sinusitis. And I will go through all of these variants. And I would again draw your attention to this really important reference by Chakrabarti that was published about a decade ago. And is really one of the best references for fungal rhinosinusitis, and has some really wonderful histopathologic images as well, and some of those which are depicted in this presentation. When we look at the epidemiology of fungal sinusitis, this is a study that looked at 400 cases of fungal sinusitis. What we find is that 87.5% of these are non-invasive, divided almost equally into the allergic fungal sinusitis and the fungal ball variants. And then 12.5% are invasive, with most of them being acute invasive, with the chronic invasive and the chronic granulomatous being much less common. So when we look at the summary slide here from this study, you'll see here for the fungal ball, again, the immunologic status is normal, prognosis is excellent, the most common therapy is surgery. For the allergic fungal sinusitis, the immunologic status is typically atopic, prognosis is good, therapy is multimodal, and really beyond the scope of this histopathology talk, but can be comprised of steroids, oral and topical surgery, oral and topical steroids, and in select cases, immunotherapy. The chronic invasive variant, typically the immunologic status is borderline, prognosis is fair, surgery and antifungals are the mainstays of therapy. For the chronic granulomatous variant, the immunologic status is typically normal. Again, the prognosis is fair. Treatment is also comprised of surgery and antifungals. And the acute fulminant invasive variant, the immunologic status here is compromised, the prognosis is guarded, and the therapy includes reversal of the underlying immunocompromise, timely and often aggressive surgery with antifungals, really all hands on deck approach, often to save these patients. So again, I'll focus on the pathology of these many variants, looking at a fungal ball, showing you endoscopy of a fungal ball removal during surgery from the left maxillary sinus. You can see that grossly the appearance can be soft, wet debris. It can be very firm and gritty, and the color can really vary anywhere from yellow, green, brown to even black. And when you look at this microscopically, you'll see this entangled mass of fungal hyphae. You'll typically see a minimal mucosal inflammatory reaction, which tends to be neutrophilic when present, and there's no concern for tissue invasion with just a fungal ball. Surgery with evacuation of fungal debris is curative in these cases. The term allergic fungal rhinosinusitis was coined by Macmillan in 1987 and really represents a extramucosal immunologically mediated fungal process, typically seen in adolescents and young adults, much more common in the South and the Southeast part of the United States. And it's associated with nasal polyps and the presence of this fungal or allergic, also called eosinophilic mucin. About half the patients can have asthma. At least 2/3 have a history of atopy. And when you look at the specific IgE to fungal antigens, these are elevated in 90% of the cases, and showing you representative images of these hyperdensities with expansion in the left ethmoid region, left maxillary, and looking at bilateral sphenoid with extension into the lateral pterygoid recess with some bone erosion in the second case. So again, another CT depiction of this, you can see these hyperdensities on the left side with significant expansion of the left frontal to the contralateral side. If you were to remove this eosinophilic or allergic mucin, you would find, again, eosinophils, Charcot-Leyden crystals, this eosinophilic debris and inflammatory cells. If you were to do this methamine Gamori silver stain, you would see these scattered fungal hyphae. If you were to send this off for cultures, you'll typically see demataceous species like Bipolaris, Curvularia, and also Aspergillus. For the invasive variants, let's first talk about the chronic invasive fungal rhinosinusitis. This is typically a slow, insidious, destructive process and will span a time course typically over 3 months. As I had mentioned earlier, the immunosuppression in this case is borderline. These can be diabetics or chronic steroid users. And when you look at the pathology, you'll see this fungal invasion of the underlying tissue. Occasionally, you can see vascular invasion, as you see here, and the inflammation tends to be relatively sparse. And if you were again to look at this with a silver stain, you can see the fungus that is evident in the tissue. Most commonly, this is due to Aspergillus fumigatus, and treatment over time has evolved. It's typically conservative endoscopic surgical debridement with long-term oral antifungals in collaboration with our infectious disease colleagues. The chronic granulomatous fungal sinusitis is a more rare variant, certainly in the United States. I've seen a handful of cases over my 20-year career. More commonly, this is seen in countries in North Africa. Also tends to be endemic within South Asia. This is seen in immunocompetent hosts, typically younger patients, and it's caused by Aspergillus flavus. This can present as an enlarging mass in the cheek, orbit, nose, or the paranasal sinuses. Proptosis has been seen to be a common feature. And again, if you were looking at the pathology of this, you would see this granuloma formation, and you'll see evidence of fungal invasion. And treatment of this is with endoscopic surgery and long-term antifungal therapy. The acute invasive fungal rhinosinusitis, compared to the chronic invasive variants, tends to be a rapidly progressive process that will take place over days, but in some cases can occur within hours. I'm showing you an example of a patient who, in a matter of a day, developed redness of the face, and then you can see the progression of this necrosis, which actually evolved so quickly where you could see the thrombosis and this necrosis spreading even while we were in the operating room. This can be seen in the setting of uncontrolled diabetes or immune compromise, which can be due to use of chemotherapy, underlying hematologic malignancy in the setting of full-blown AIDS, and variety of other immunocompromised conditions, caused most commonly by zygomycota, such as mucor and rhizopus, or ascomycota, so aspergillus can also cause this sort of a clinical picture. When you look at the nasal mucosa, it can be dusky. You can see these bloody crusts. You can see a black eschar on the left middle turbinate, as you see here. Orbital involvement can result in chemosis, proptosis, even ophthalmoplegia. And you should also look at the oral cavity, as you may see extension inferiorly, resulting in a palatal eschar or necrosis of the palate. If you were to look at this histopathologically, you will often see this tissue infarction, and you'll see this can see vascular thrombosis, and you'll see very scant inflammatory cells, and that intuitively should make sense. These patients are immunocompromised, and they're really not mounting an immune response to the fungus. You can also see angioinvasion of fungal forms that can result in luminal thrombosis, which can in turn accelerate the necrosis. And again, by silver stain, you can see evidence of mucor in the underlying tissue. We've done some work on this as well, and we've shown that frozen section analysis can be crucial in rapid diagnosis and intraoperative decision-making, showing a positive predictive value of 100% in our cohort of patients. So we'll now conclude with some information on benign sinonasal tumors. Again, I'll talk specifically about sinonasal papillomas, and then we'll transition to fibroosseous lesions, focusing on osteoma and fibrous dysplasia. A little bit of background on sinonasal papillomas. These are the most common primary sinonasal tumors. Data from the Danish registry notes that the incidence of sinonasal papilloma is roughly about 1 per 100,000 patients. The key thing to note here is there are 3 distinct entities that we deal with, most commonly the inverted variant that we operate on, but also the exophytic and the oncocytic variants. And I'll talk about each 3 of these in detail here. So first, we have the exophytic papillomas. These typically arise on the nasal septum, as you see on the left-hand side here. You see this papilloma arising, and you see this has been excised. And if you were to look at this histologically, you'll see this stratified squamous epithelium, and this is exophytic and arising outwards with this a soft tissue connective core. And if you were to do a viral subtyping, there's a high association of HPV, and studies have shown that 2/3 to 3/4 of the cases will have presence of low-risk variants of human papillomavirus, showing you another endoscopic example of a multifocal exophytic papilloma arising in the nasal septum, but also along the lateral nasal wall here. Now contrast that to inverted papilloma. This is the left side. You see this large exophytic papillomatous mass filling the left nasal airway and obstructing the middle meatal structures. When you look at this histologically, this will have an endophytic growth pattern where this stratified squamous epithelium actually inverts down into the underlying stroma. You can see presence of respiratory or transitional epithelium, and for benign IP, typically you'll see minimal to no mitoses or atypia. This is why inverted papilloma can be more aggressive. It can invade down into the underlying bone and can result in risk of recurrence if you don't remove this aggressively to the point of attachment, with typically drilling or even removal of bone if technically feasible, to ensure complete clearance of the margin where it has this endophytic pattern and invades down into the underlying point of attachment. And the last subtype is the oncocytic, or also called the columnar cell papilloma. And what's interesting is grossly, endoscopically, this looks no different than the inverted papilloma. Here is a case of a maxillary sinus oncocytic papilloma that was sent to me many years ago. This looks no different than the inverted papilloma. But what's different is when you look at these histologically, typically you'll see this columnar epithelium with this outgrowths to the nasal mucosa. This also tends to be unilateral, arising from the lateral nasal wall, and in about 10% of the cases, similar to inverted papilloma, this can be associated with malignancy as well. Again, detailed discussion of radiology and treatment is beyond the scope of this, but I wanted to make sure that I could share with you the key histologic features of these 3 subtypes of sinonasal papilloma. Moving on to fibroosseous lesions, and there's really 3 classic entities that we focus on. Osteoma, which was described back in the 1500s by Viega. Fibrous dysplasia, first described by Lichtenstein in 1938, and ossifying fibroma, described by Montgomery in 1927. When we look at osteomas, these are really the most common fibroosseous lesion, and if we call it really a tumor of the paranasal sinuses. When you look at plain films, the reported incidence can range anywhere from 0.014% up to 0.43%. If you were to use CTs, the incidence that's reported can go all the way up to about 3%. These most commonly occur in the frontal, followed by ethmoid. Maxillary and sphenoid are much more rare. Showing you a couple of CT examples. This is a patient with a large frontal osteoma that's extending into the frontal recess. This is resulting in a post-obstructive mucosa, which actually resulted in periorbital cellulitis, thus necessitating surgery to remove the osteoma and drain the post-obstructive infection above the area. Here is a large ethmoid osteoma that extending into the orbit caused subtle lateral displacement of the orbit, but the actual presentation of this was pneumo-orbita after nose blowing. The patient had some left-sided orbital pressure as well and necessitated removal, which was performed purely via the endoscopic route. When you look at osteoma histologically, typically what you'll see is this dense lamellar bone that's interspersed with this fibrofatty tissue in the interstice. And there's three histologic variants. There's the hibernated type, or what's also called the ivory or compact osteoma. These tend to be much more dense, lack any sort of Haversian canals. You can have the mature type or the osteoma spongiosum, like you see here. And in this case, this is a softer bone, very similar to cancellous bone, or you can have a mixed type, which can contain elements of both the eburnated and mature forms. When we look at fibrous dysplasia, again, this is not a true tumor, but is really a slowly progressive disorder characterized by replacement of the normal bone with this fibrous and woven immature bone. You have three subtypes. You have the monoostotic fibrous dysplasia, which is the most common and represents about 80% of the cases. Polyostotic fibrous dysplasia, which is about 1/5 of cases, and the McCune-Albright syndrome, which is rare, but includes the polyostotic fibrous dysplasia and includes sexual precocity and also cutaneous pigmentation like the cafe au lait spots. So here you can see the fibrous dysplasia. You can see here these irregular spicules of bone, again, embedded in this fibrous stroma, and what's been called the Chinese character appearance. Now, what's different is that if you were to look at this relative to a true tumor, such as a ossifying fibroma, there is no osteoblastic rimming that's seen with fibrous dysplasia. If you had an ossifying fibroma, you would expect to see osteoblastic rimming present here. And that's really the key differentiating feature between fibrous dysplasia and even osteoma relative to ossifying fibroma. And just showing you a couple of examples. This is a fairly classic example of a fibrous dysplasia. This one involves the frontal sinus and the frontal bone and what's been classically referred to as the ground glass appearance. But please don't be fooled. Long-standing fibrous dysplasia can lose this ground glass appearance and you can see more of this kind of speckled heterogeneous pattern of what's called the cotton wool appearance. So you should be familiar with both of these variants. We've also looked at this data and looked to correlate the CT findings with histopathology. This was a paper that was published about a decade ago. And typically for the radiographic appearance for osteoma and fibrous dysplasia, there is good correlation to the preoperative CT imaging with the histopathology. Therefore, majority of these cases can be observed, and you really don't need biopsies unless there is any sort of equivocal findings on CT imaging or concern for a true neoplasm such as ossifying fibroma, which may necessitate biopsy for further patient counseling and formalizing a definitive treatment plan. So I'll summarize with some key points that I was hopefully able to relay to you today. And these are the key points. So paranasal sinus mucosa is composed of a ciliated pseudostratified columnar epithelium with submucosa that's comprised of seromucinous glands and a mixed inflammatory infiltrate. When you look at CRS with nasal polyps, you can still have the pseudostratified columnar epithelium, but that can revert to more of a transitional or a squamous epithelium. The underlying submucosa has a very loose stroma, often with severe edema, sparse glands, and abundant inflammatory cells, which tend to skew to eosinophils. As I had demonstrated earlier, the structured histopathologic reporting has a potential for important implications for management of CRS and its subtypes. When we look at the fungal rhinosinusitis, it's divided into the invasive and non-invasive subtypes, which tend to have key distinguishing subhistologic features. And the fungal hyphae can be seen with silver stain in both types of variants. And again, sinonasal papilloma is comprised of the three distinct entities of inverted, exophytic, and oncocytic subtypes that have key distinguishing features and also management strategies. I want to thank you all for your attention. I want to thank the editors for the opportunity to speak with you about this important topic. I think this is a area that is a key foundation of management of these patients and ultimately to surgery. I would refer you to these key references that I utilized to develop this presentation, and some of these key studies were from the Wenig textbook, the International Consensus Statement of Rhinosinusitis, which was updated in 2021. Some of the key studies from our work on structured histopathology and this publication by Chakrabarti. Thank you.